Hello everyone again, my name is Vadim Koshkin with GU Oncology Now. Today I have with me a very special guest, Dr. Terence Friedlander, who is actually my co-leader of the bladder cancer program at the University of California, San Francisco. And today he will talk about the EV-103 study, specifically the 18-month update that was presented at this ASCO conference. Terry, maybe to start out, just summarize quickly EV-103 as a trial.
Sure. So EV-103 is a multi-arm study looking at the combination of enfortumab vedotin with other partners. Cohort A, which began enrolling a few years ago, specifically looked in frontline metastatic bladder cancer patients who were cisplatin ineligible, who traditionally would get a carboplatin-based regimen, and that investigated a combination of enfortumab vedotin, which is an antibody-drug conjugate against Nectin-4, together with pembrolizumab, a PD-1 inhibitor. That cohort initially reported out now a few years ago. There were 45 patients accrued, and we saw pretty interesting results. I would say pretty impressive results in terms of efficacy, both in terms of a response rate, which was 73% in cohort A, and then subsequently longer-term outcomes, actually some of which were updated here at this meeting just today, which showed a median OS of over 2 years in this population. And just for reference, if we jump back 10 years ago, the data from phase 3 studies of carboplatin and gemcitabine in the pre-IO era showed a median overall survival of 9 months. And so with cohort A, we were seeing 26 months, and that was pretty impressive. The toxicity seemed to be pretty manageable from cohort A, sort of what you would expect from both EV and Pembro when given together, but there weren't really any new safety signals or synergistic, toxicity. That data was presented, was taken to the FDA, and the FDA recommended doing a larger study and also including a cohort of patients getting EV monotherapy. Because while EV had been investigated in a phase 3 trial in the metastatic setting, in the late line setting, it had never been investigated in the frontline setting, and so it wasn't really clear what the toxicity would look like. So that was really the impetus for the cohort K opening, essentially, which compared EV Pembro, and separately there was a cohort of EV alone. These were non-comparative cohorts. We have to be careful about making a lot of sort of cross-cohort comparisons, but really to give us a sense of what each drug might be contributing. So that was really the rationale for the study.
Yeah, so that's a great summary. And the first results of cohort K were actually, as you mentioned, presented just a little under a year ago at last year's ESMO. Maybe just a quick summary of that.
Yeah, so with cohort K, what we saw was the response rate was what was reported at ESMO. We saw that there was, for EV monotherapy, the response rate was 45%, while for the combination it was 64.5%, or thereabouts, you could say 65%. And that was pretty reassuring, because we'd seen that for enfortumab vedotin in late line settings, after platinum, after PD-1 inhibitors, the response rate was right around 45% as well. So there was actually a remarkable consistency in how well EV performs in metastatic bladder cancer, regardless of prior therapy. So when we saw that, we said, okay, that's good. But the extra 20% boost by giving pembrolizumab was also pretty exciting, because now we're seeing more than half of patients having clinical responses. And in fact, only about 8 or 9% of patients were having progressive disease as their best response to therapy. So almost everyone was having stable disease or better. At ESMO, at the time of ESMO, the study was not very mature. In fact, when you looked at overall survival, you couldn't yet detect a difference in overall survival rates between the monotherapy arm and the combination arm. Even though we're not really supposed to compare these, we sort of look just to get a sense. And at the report we have here today at ASCO, which is now 18 months of median follow-up for the study, so the study is really starting to mature, we've actually seen that the combination cohort, the median overall survival has not yet been reached, while for the monotherapy cohort it was reached and is still fairly impressive at around 2 years.
Yeah. And what about PFS? Is that data also mature?
Yeah, so the PFS interestingly followed a very similar trend, where at this meeting the PFS has not yet been reported, or not yet reached, I should say, for the combination arm, while it has been reached, and it's I believe around a year, if I recall right, for the
monotherapy.
Yeah, exactly.
Yeah, I will also say the monotherapy data itself is pretty intriguing, right? frontline drug in metastatic bladder cancer with median overall survival, I believe, is like 21 months or so.
Yeah, so I think it's quite interesting because we're talking about a cisplatin ineligible population, and earlier I mentioned the median overall survival for that group is only about 9 months. Median PFS for carboplatin and gemcitabine given together is only 6 months. And so as monotherapy, EV is actually performing fairly well in the frontline setting. Now we have to take some of those older data with a grain of salt because we didn't have PD-1 inhibitors, and really the standard of care in bladder cancer today is not just carbogem or cisgem, it's really those drugs followed by avelumab maintenance. And so when what we don't really have today is a study that directly compares cisgem or carbogem followed by avelumab maintenance with EV and pembro. And that's what we're really looking forward towards the randomized phase 3 study, which is called EV-302, which is specifically looking at this comparison of EV pembro versus cis or carbo with gemcitabine, with avelumab maintenance being allowed as a late amendment to that study.
Yeah, you stole my thunder there. I was going to ask you about the next steps, but it's almost like we've talked about this before.
Yeah, we might have.
Yeah.
So that phase 3 study is actually already fully accrued. We at UCSF are not taking part in the phase 3 because we had this current trial open and there was a lot of overlapping entry criteria. However, we hope that the study will be reported out in the coming year or 2 years. I think it's going to be an interesting trial. It compares, as I said, EV pembro versus platinum chemotherapy, and we'll look at subsets to see, is EV pembro better than carbogem plus minus avelumab? I suspect it will be based on the data we presented here, but we have to see. Will it be better than cisplatin gemcitabine followed by avelumab maintenance? And that is really unknown. We've never really compared those head to head. So there's going to be a lot that we're going to learn in that study. And hopefully we'll see good results.
Yeah, so certainly very promising efficacy of this combination regimen, EV and pembro. Comment a little bit maybe on the toxicities and the safety.
So as I mentioned earlier, the toxicity is really, there were really no new safety signals in this study. The toxicity we see is really the toxicity of each drug individually. Enfortumab vedotin can cause neuropathy. That's probably the most common side effect, or at least the one that patients notice the most. It's very dose dependent, with neuropathy typically presenting about 3 months into therapy, or maybe a little shy of that, but then being persistent and really not resolving for the majority of patients, although it can be responsive to dose reductions or even dose delays. The autoimmune toxicity we saw was pretty much what we'd expect with pembrolizumab. There was a pneumonitis seen in the combination arm, and there was pneumonitis seen in some of the earlier studies of EV. Low rates, we're talking on the order of 6 to 8% or maybe 9%. And so whether that's just an artifact of a small study where you might have excess toxicity observed that may or may not be borne out in a phase 3 study, we'll have to see. The other side effects that you expect from this regimen, besides the neuropathy, is really skin side effects. There can be serious skin reactions, including Stevens-Johnson syndrome. Hyperglycemia can be an issue, and I think we have to exercise a lot of caution in using this in patients who are obese, patients who have an A1C greater than 8, or patients who have blood sugar greater than 250. That's probably mediated by the vedotin aspect of the payload of the enfortumab. And then ocular toxicity was also seen at a low level, and that's well described with EV as a treatment. But overall, we've treated patients together at UCSF who've been on this regimen. I would say it's fairly well tolerated. And considering where we were 10 years ago with carbogem plus minus avelumab more recently, I think it's a big step forward. We just really need to see the data borne out in the larger randomized study, and hopefully we'll see that pretty soon.
Absolutely, yeah, and we're awaiting that eagerly.
Yeah.
Well, Terry, congratulations on, again, the wonderful data at this conference, and your poster was a huge hit, and we look forward to seeing
Thanks
more
so
from this
much,
trial.
and honestly, thanks to all the investigators, co-investigators, the companies that sponsored the study, and really to all the patients who took part, because they're really, we couldn't do this without them. So.
Yeah, absolutely.